we are going to talk on the vascular system. So we have our veins and our arteries. Right, our big major veins are going to be break down into venules, and then we mix here at our capillary beds, where it then enters arterioles into our major arteries. Our blood vessels each have 3 layers. Our intima, which is our endothelial layer on the inside of both veins and arteries. Veins also have valves within the intima. The media, the tunica media, that is our smooth muscle, which we can see is much bigger in an artery and a vein. And that's because our arteries have to be able to constrict and dilate, so they need more muscle. And then our tunica externa is just that outer layer. So our vascular system, it carries nutrients and oxygen and blood to our tissues. Blood flow should be unidirectional. Times when it's not is when we have like valve disorders, valve insufficiencies. It gives us our blood pressure and is important for our hemodynamics. So blood pressure is the amount of force that is needed to open the aortic valve, right? So the pressure of our systolic blood pressure, right, that is the pressure that is our valve opening. And then diastolic is the pressure of once it's closed. It's our highest left ventricle pressure over our lowest. Normal is less than 120 over 80. Again, we've talked about pulse pressures, and then our mean arterial pressure is going to be what we focus a lot on. We want our MAP to be above 65 in order to perfuse our kidneys and our brain. But we also want to watch our systolic, right? Our systolic should be about that 90 to 120 range. Blood pressure can also help determine like our cardiac output, right? It's our cardiac output times our systemic vascular resistance. So if we have a poor cardiac output, our body is going to vasoconstrict, increase our SVR to increase our blood pressure. We have a good cardiac output, we can vasodilate a little bit more to have a good blood pressure. Our SVR is determined by baroreceptors. It's also going to be controlled by some chemical factors such as like nitric oxide, carbon dioxide, as well as, carbon dioxide, as well as oxygen. So some mechanisms that control our blood pressure, right? We have our RAS system, vasopressin, which is also our antidiuretic hormone, and then epinephrine and norepinephrine. So these are going to be our catecholamine hormones. They're also going to increase our heart rate and our cardiac contractility to help increase that blood pressure. RAS is going to cause vasoconstriction and sodium and fluid retention. Same with our vasopressin. So hypertension is systolic greater than 120 or diastolic greater than 80. We have primary and secondary. Most hypertension is going to be primary hypertension, where we don't necessarily know what the cause is. Secondary is when we know the cause, right? Such as pregnancy or some sort of constriction that we can fix surgically, or like a renal disease. And so if we remove the kidney, then that blood pressure goes away or gets better. Symptoms of hypertension, right? Headache, migraines. Some long-term issues is going to be our coronary artery disease, chronic kidney disease, cerebral infarct, so stroke, left ventricular hypertrophy. Some interventions, right? If our patient is super hypertensive, we can set them up. Okay, reduce that blood flow to the brain, reduce stimuli, and then treat our cause, right? Pain, anxiety, treat those and hopefully lower our blood pressure. Goal is to have 140/90 or below. Some primary treatments can be lifestyle changes, diet, exercise, or medications. A hypertensive crisis, so this is an emergency. So these are going to be blood pressures in the 200s, right? In order for it to be considered a hypertensive crisis, we need to have some end organ dysfunction. So this can be decreased urine output. This can be a headache, confusion, tiredness, elevated liver enzymes. This could be an elevated troponin, chest pain, anything like that, where we have so much force, right? Our blood pressure is so high that we are clamped way too down. And so we're vasoconstricting so much that we're actually impeding blood flow to organs like our brain and our kidneys. We want to decrease our blood pressure by 20 to 25% within the first hour, and then our goal is to be 160/100 by 6 hours or lower. And we really want to assess these patients. A lot of times they live super hypertensive, so they might have symptoms of hypotension when we get into these lower numbers. Our medications that we can give, so we can give nicardipine or cardine, it's down here twice, either as an oral medication or in a drip. That's one of our calcium channel blockers. We can give sodium nitroprusside or nipride, you'll hear it called. And that's another IV medication that's a pretty potent vasodilator. We can also give nitroglycerin and labetalol. So labetalol is one of our beta blockers that's very potent and works a lot on the beta receptors in our blood vessels to cause vasodilation. We'll also want to do some of our non-pharmacological interventions, such as darkening the room, right, reducing stimuli, turning the TV off, telling them not to get on their cell phone, asking family members to leave if necessary, right? If the family member walks in and their blood pressure gets higher, we will ask them to leave. They might have an A-line placed so we can accurately see what our blood pressure is, especially if we're giving these medications. So we want to make sure that we're not getting too low and that our interventions are working as well. Sometimes a non-invasive cuff isn't very accurate when we get to those high numbers because it doesn't blow up high enough, and might miss a higher blood pressure. Hypotension, right, it's going to be patient dependent, so assess your patient. Some of them live with a systolic of 88 and they're fine, right? Especially a lot of our renal failure patients can be a little bit more hypotensive. So assess your patient, right? But we definitely want this map. Okay, this is going to be telling us if we're perfusing our kidneys or our brain. That's our average blood pressure through the whole cardiac cycle. Some symptoms: confusion, dizziness, lethargy, right? They might have that impending doom, weakness, decreased urinary output, chest pain, headache, pale, cool extremities, diaphoresis, right? Signs of poor perfusion. Some interventions: we can lay our patients flat or even elevate their legs. Okay, raising their legs up a little bit is about equivalent to giving them a 250 bolus. So if we have a fluid problem, right, and we put our legs up, that can tell us that our patient needs fluids and maybe not like something for like vasoactives. And then treat our cause. Okay, if our tank is empty, it's going to stay empty unless we treat it, right? If our patient is septic and that's causing our hypotension through an acidosis, then we need to treat that sepsis with some antibiotics before we're going to see any improvement in our hypotension. So we can give fluids, right? We can give blood, our volume expanders or albumin, and then our vasopressors. And usually the order of vasopressors is we're going to start with our norepinephrine or our Levophed, and then, which is one of our catecholamines. Then our vasopressin, which is going to retain fluid and cause some vasoconstriction. Then depending on your doc and what's going on, will determine whether we go to epinephrine or phenylephrine. So this is also called NEO, you'll hear. These medications need to be given in a central line. In an emergency, we can use a peripheral, but they need a central line, such as a PICC line or an IJ. No midlines. And then we can also give midodrine. So midodrine is an inotropic, and it's going to help our blood pressure by increasing our cardiac output. So these all affect our SVR, our systemic vascular resistance, and like our epi, our phenyl, and our levofed, those can help increase our cardiac output as well, where midodrine's just going to increase that cardiac output. So an aneurysm. So aneurysm is a weak point in the arterial wall. So that inner layer, your endothelial layer of your blood vessels, has some sort of injury, which is going to cause it to kind of slough off, and we're going to have bleeding between the tunica media and the tunica intima. We generally see them in the thoracic cavity or abdominal aortic. So our abdominal aortic, this is going to be more common than thoracic. So these are our triple A's you'll hear in abdominal aortic aneurysm. Most common cause for these is atherosclerosis, right? That atherosclerosis causes a weakening of that tunica intima and allows for some sort of injury and for that layer to slough off, and then we have bleeding. A most common site for a dissection is going to be right on our thoracic, and that's because of our aortic arch here. So here's our aorta. And so if we have atherosclerosis here, okay, and this is the highest point of blood pressure, if it's hitting here, it can cause all of this to slough off, and then now we are bleeding into the tunica intima, tunica media of our aorta. And it's going to be dissecting, so it's just going to keep peeling off. And we're just going to continue to bleed in here. So if blood is in our aorta, it is not getting to our body. This is a medical emergency. A lot of the time, patients don't survive this because you have minutes to get them into surgery. So unless they're lucky enough to have this happen, like in the hospital, a lot of time we don't have time to get them to the OR and get them fixed. So, sorry. So symptoms of a thoracic aneurysm. We can see some like venous buildup, right? So we're having kind of a backflow of blood from our aorta. So we can see JVD, we can see edema of the chest, upper body, cyanosis. We can see unequal pupils because we're not able to drain our venous blood flow appropriately. These patients are going to come in and they're going to have this sharp chest pain in the middle of their chest. They're going to say, it feels like I got kicked by a horse in my chest. My chest has never hurt so bad before. And it radiates into my back, maybe in the shoulders, but mostly chest pain that radiates to the back. That's going to be indicative of a thoracic aneurysm. Diagnosis is going to be a CTA because we want to be able to see where that blood is settling. So they're going to have contrast. And then treatment is surgery and then blood pressure control. We got to get that blood pressure down to help reduce our bleeding. We'll also see signs of bleeding, right? So we're going to see a low H&H, hypotension, tachycardia, all of that. And then our abdominal aneurysms, These can be a little bit more chronic. Again, these are less likely, right, to dissect, but more common to have them. And so you might see or feel some pulsation in their abdomen when they're lying flat, and that's just because this aneurysm, and this is their abdominal aorta, this is their aneurysm, this is going to fill with blood and pulsate as our heart beats. If this were to rupture or is big enough, they might complain of severe back or localized abdominal pain. You might hear a bruit because as blood comes in here, it kind of eddies. So it's going to swish. And so when it eddies, it also is at a risk of clotting. These guys will have a decreased hematocrit, maybe not so much a decreased hemoglobin, just because they're not necessarily bleeding. We can diagnose this with a CTA or a transesophageal echo. And the management is going to be blood pressure, and then we can place a stent in these. So the stent goes in just kind of like through the femoral artery. Most of the time, these aneurysms are just right above our iliac arteries, right? So here's our iliac, here's our femoral. So we go in the femoral, and we can place this stent, which is just going to cover this. And then our body's going to heal around it to help focus our blood flow. And then we don't have a risk of rupture from this weak tissue here. So a dissection, right? This is going to be our medical emergency. We have shearing and occluding of the arteries, lots of bleeding. And then this is that severe chest pain, back pain, epigastric abdominal pain. They're going to look like a hemorrhaging patient because they are. They're internally hemorrhaging. Tachycardia, diaphoretic, GI upset, hypotensive, anemic, all of those symptoms. So our peripheral arterial disease, again, back to atherosclerosis, right? So we have an endothelial injury of an artery. Myocytes enter the endothelium, transform into macrophages. They're going to eat our LDL, oxidize and become these fat foamy cells. Our foamy cells are unable to exit the tunica intima underneath that endothelial layer. And they're going to die and become necrotic. And as they become necrotic, they are going to become calcified. And now we have this big hardening of our arteries. So peripheral artery disease, 50% narrowing of the lower extremities. We can see this intermittent claudication, right? Pain with walking just because of our higher oxygen demand, signs of reduced blood flow. So it's going to be our pallor, pulselessness, pain, paresthesia, polar, paralysis, right? Patients with peripheral artery disease are going to have decreased blood flow, so we'll see paleness, pulselessness, pain because we have decreased oxygen, maybe some tingling because of that decreased oxygen, polar because we don't have any blood, and then paralysis, again, decreased oxygen to that muscle tissue, to those nerves. If we have an emergent occlusion, that's when we'll see that pistol shot, and that's when we have all of these symptoms very quickly, where we can see these chronically in somebody who has long-term peripheral artery disease. So management, we're going to give them medications to lower their cholesterol, and also it's going to help stabilize that plaque. Medications to help treat hypertension, and then anticoagulants as well. We're going to do everything we can to prevent any clotting and occlusion happening with peripheral artery disease. We can do angioplasty, so we can go in, similar to what we do in coronary artery disease, and place a balloon. We don't always stent peripheral arteries because they move so much, right? We have a bunch of hinge points, so our hips, our knees. We don't ever want to place stents around those areas, and that's generally where this atherosclerosis forms the most, but we can use a balloon to widen the lumen. And then we could do a atherectomy. So atherectomy is just removing the atherosclerosis. So they'll use a laser or lithotripsy. There's also this device. It is a wire, and on the wire is this little ball with diamonds on it, and it spins around super fast, and it kind of sands down the atherosclerosis, and then down here will be a filter to catch any debris so we don't have any clots downstream. Pretty gross, but it works really well. Lots of pain though, so we want to make sure if we're having that done that our patient's pain is managed well. And then stenting, and then endorectomy is when they do surgery and go in. This cutting and lasering, they can do this in the cath lab. This will be actual surgery. So our nursing management, right, we want to promote arterial dilation. We can do heat, but remember if these patients have that they have alterations in sensation, okay, we don't want to do anything too hot because they won't be able to feel if they're being burned. Avoidance of vasoconstrictors such as nicotine. Okay, we're going to do our frequent assessments of pulses, color, our CMS, circulation, movement, sensation. Assess for bleeding after an intervention, so assess for bleeding at our sites. Okay, pain relief. Tissue integrity is a big one, right? Our skin's our biggest organ. We need to take care of it, so we need to make sure it's clean and dry. Changing our patient's positions every 2 hours if they're bedbound, or even just getting them up. Dressing changes if they have any ulcers, and then lots of education. So our venous insufficiency, our veins are low pressure and they're going to rely on skeletal muscles, changes in our intrathoracic pressures to return blood flow, changes in the abdomen, right? That's why it's so important for our patients to sit up and move around. That actually helps promote that venous return of blood flow. But if we are also in heart failure, right, our heart isn't strong enough to pump blood forward, which can cause some venous insufficiency as well. So in our lower extremities, we see this as varicose veins. And we also worry about like DVTs. So our deep vein thrombosis can be a result of venous insufficiency. Vasculitis. So vasculitis is inflammation of our vascular system. It can be of the veins or of the arteries. Lots of causes, right? So we can see this with Kawasaki, cancers, infections, lupus, rheumatoid arthritis. A lot of our autoimmune disorders, there's disorders that can have vasculitis of just the kidneys or just the retinas, or our IV drug use. So symptoms, a fever, right? Because we have a whole bunch of inflammation. We're going to have a big prostaglandin response. Pain, headache. They can develop a rash. So they'll have this really red rash in the area that's affected. It can be a systemic rash. It can just be in their legs, in their arms. Muscles and joint pain, again, because we have that massive inflammation. So treatment is going to be steroids, anti-inflammatories, aspirin, and then blood thinners, right? Because with that inflammation of our vascular system, our endothelial cells get inflamed, and they can start having injuries, so we can start forming little microclots, which can then cause a thrombus and all sorts of problems. So a venous thromboembolism, VTE, so this is going to be like our PE or our DVT. So we have Virchow's triad, which is endothelial damage, venous stasis, and altered coagulation. Altered coagulation can come from any inflammation. So if we think about our patients in the hospital, they almost all have this, right? If they've had surgery, they have endothelial damage. They're laying in bed, they have venous stasis, and they have some sort of inflammation, which is going to cause altered coagulation. Altered coagulation can also be caused by hypothermia, so if our patients are too cold. So that's why we get our patients up and walking. That's why we're going to give them prophylactic Lovenox or heparin. Okay, so symptoms of a DVT usually, right? Because a DVT is going to cause a PE. Most PEs, almost all of them, are caused by a DVT, which is preventable. We can prevent this in the hospital. So unilateral swelling just in one leg of the clot. That swelling is going to be because we can get blood down to our feet, but we can't get it back. Okay, so we should still feel pulses. Our pulses might get weak if our swelling's really bad, but a DVT shouldn't affect our arterial system, just our venous. Venous gangrene or venous ulcers, right? Tenderness, hot, warm to touch, red, and then Homan sign. So when your patient flexes their foot, flexes that calf, it increases the pain, and that can be sign of a blood clot. Signs of a PE are going to be shortness of breath. We can see some EKG changes, hypoxia, tachycardia. We can see changes in our hemodynamics, such as hypotension, right? If we can't get blood through our lungs, it's not getting to our left ventricle very well. So prevention, right? Our SCDs and ambulation. Ambulation is a big one, right? We got to get our patients up and walking at least 3 times a day unless ordered otherwise. Our medications are low molecular weight heparin, our Lovenox, anticoagulants such as warfarin, Eliquis, Plavix, Xarelto, those all count towards VTE. Our Brilintas, our Effients, our aspirin does not count. So even if they're on those medications, they still need to be getting something else for DVT prophylaxis. And then thrombolytics, you're going to treat it, right? That's like our TPA. And arterial embolism, so this is our medical emergency, right? This is going to be our 7 P's, 6 P's, pistol shot, polar, pallor, paralysis, pulselessness, pain, paresthesia. This can be caused by us, right? Some sort of iatrogenic injury, such as stent placement, and our stent moves or is dislodged. Okay, we place a balloon pump in the femoral artery and we clot the femoral artery off. We place an impella in the femoral artery and it clots and sends some sort of embolism downstream. Trauma. AFib is not one. AFib can cause RPEs. That's for sure. Oh, no, wait. I lied. AFib is one. And myocarditis. So, treatment, endovascular management. So that just means we want to be very cautious of any devices that we're placing in the arteries, or we can go in and place a filter and actually break up the clot, catch it in that filter, and pull it back. So there is a device called an ECOS catheter, and so an ECOS catheter, it is a little wire, and it'll go right above our blood clot, and it vibrates, and it also will drip TPA. So the TPA helps dissolve the clot, right? It's plasminogen, and then the vibration helps break the clot up a little bit as well. So we can do an ECOS catheter for arterial embolism. We can also do it for PEs, and then anticoagulants and activase. Okay.